Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, I'm Dr. Ashwani Singal, Professor of Medicine at the University of Louisville. Welcome to this clinical clips from the Liver Meeting 2024. This is day 2 of 2. In this video, we will present 4 abstracts from the AASLD Liver Meeting on primary biliary cholangitis. The first abstract, this is a global snapshot of PBC practice around the globe in terms of choosing the second-line drug for the treatment of patients with PBC. So we know that there have been some safety concerns with obeticholic acid or OCA, and in the emerging therapies and emerging evidence that drugs like fibrates and PPAR agonists, this has changed the treatment paradigm for PBC patients. And the practices have been heterogeneous with some observations showing that the different providers choose different drugs for second-line treatment when they need to add to patients who are already on UDCA. A total of 1,785 patients were studied or analyzed, of which 917 initiated on OCA, and 868 were initiated on fibrates as a second-line therapy. The reason for choosing fibrates was restricted access to OCA at 19 centers in countries like Japan, Argentina, Netherlands, and Belgium. The median time from UDCA initiation to the second-line treatment was longer for OCA patients at about 71 months versus 53 months for the fibrates, and this was statistically significant. The proportion of females was similar, comparing fibrates versus OCA. Baseline cirrhosis was more frequent in OCA patients at about 28% versus about 20%, and this was child A and higher in OCA at about 98% versus 64% child A in fibrate-treated patients. On follow-up, 96 patients receiving OCA as a second-line drug had to add a fibrate, whereas only 22 patients who received fibrate as a second-line drug had to add OCA over time. OCA was discontinued by 33%, mainly due to pruritus, and of these, 128 patients switched to fibrates. On the other hand, fibrates were discontinued in only 21%, mainly due to increased liver enzymes or worsening renal function, and 39 patients switched to OCA. So the authors conclude that the management of PBC demands dynamic adjustment to second-line treatments, and high discontinuation and change rates underscore the urgent need for better allocation tools. So the second abstract, exploring the impact of baseline alkaline phosphatase levels on endpoints in PBC. And these were post-hoc analyses of patients enrolled in the ELATIVE trial. So in this ELATIVE trial, ALP or alkaline phosphatase normalization and change from baseline in alkaline phosphatase at week 52 was analyzed in subgroup of patients based on their baseline alkaline phosphatase. A higher proportion of patients who received elafibranor achieved biochemical response or normalization of ALP compared with placebo-treated patients, regardless of which category the baseline alkaline phosphatase level was seen or observed. Further, the overall lower baseline alkaline phosphatase levels tended to give you higher response rates. Larger reductions in alkaline phosphatase from baseline were seen in patients receiving elafibranor compared with placebo, regardless of baseline alkaline phosphatase levels. Reductions in alkaline phosphatase in patients receiving elafibranor were relatively consistent across all baseline alkaline phosphatase subgroups. So the authors conclude efficacy of elafibranor in patients enrolled in ELATIVE trial across the spectrum of baseline alkaline phosphatase values. Patients receiving elafibranor with lower baseline values had higher biochemical response and normalization of ALP rates versus those with higher baseline alkaline phosphatase levels. In this presentation, the third abstract, which talks about complication-free survival in a real-world setting cohort of PBC patients, the authors are comparing deep versus adequate ALP response, and the drug used was UDCA, which is the first-line treatment for PBC patients, as we know. So in the target PBC study, which is a longitudinal cohort of PBC patients who received usual care and observed for over 5 years across multiple sites in the US, that was used for data analysis. The eligibility criteria for this particular study were patients who had a recorded starting date of UDCA. There was no second-line therapy used at any time point during treatment and have met adequate response to UDCA according to the Paris 2 criteria. The primary outcome of interest was complication-free survival, defined as the time from enrollment into either the deep or adequate response cohorts to the occurrence of a serious clinical event. So of the 232 patients, of which 147 met the criteria for adequate response, were analyzed in this particular observation. On examining the Kaplan-Meier curves, serious clinical event reduced in patients achieving deep versus adequate alkaline phosphatase response by 64%, and the similar figure was 77% decrease when the deep versus adequate total bilirubin response was analyzed for the response to bilirubin. These significant findings were mainly contributed by patients who had advanced fibrosis. So the authors conclude that the deep ALP or bilirubin response is associated with improved complication-free survival in PBC patients, especially in those with advanced fibrosis. These findings are suggestive that patients with advanced fibrosis are likely to benefit from more aggressive therapy and trying to achieve normalization of ALP and a deep bilirubin response, which is bilirubin down to 0.6 times upper limit of normal or below. The last abstract in this presentation, which is talking about volixibat for cholestatic pruritus in PBC. This is an adaptive, randomized, placebo-controlled phase 2b trial, also called the Vantage trial, and these are the interim results. We know that volixibat is a minimally absorbed ileal bile acid transporter inhibitor that interrupts enterohepatic recirculation, and by inhibiting the bile acid uptake in the small intestine, volixibat leads to increased bile acid elimination in feces and reductions in the systemic bile acid pool and helping patients with pruritus in PBC. The objective of this study is to report the interim analysis and dose selection for this phase 2b randomized multi-center double-blind placebo-controlled study evaluating the efficacy and safety of volixibat in treating cholestatic pruritus in adults with PBC. So what this study showed, of 31 patients analyzed, 10 each in the 2 intervention arms and 11 in the placebo arm, the mean change in pruritus score, which is the decrease in pruritus score, was 3.7, 3.9 with the active drug, and it was only 1.3 with placebo. And these were statistically significant for both doses of the active medication, which is volixibat. Serum bile acids response was also observed in 80%, 60% and 36% of patients. Quality of life improved with both the doses of volixibat significantly. In terms of the side effects, diarrhea was reported in up to 77% of pooled participants, which is 17 of 22 patients receiving volixibat, and this was mild in severity. There were no clinically relevant changes in total bilirubin, ALT, AST, or alkaline phosphatase with the active intervention compared with placebo. Treatment-associated adverse events, grade 3 or higher, included a suicide attempt and syncope in 1 patient, hyperbilirubinemia and liver function test increase in 1 patient, and drug-induced liver injury due to ibuprofen and alcohol. 2 patients in the high-dose volixibat 80 milligram group. A placebo patient also had an adverse event, small intestine obstruction, which was reported in this study. Treatment-associated adverse events leading to premature discontinuation of study drug, although was very rare, including diarrhea in 1 patient only who received volixibat at a dose of 20 milligram, and another patient in the placebo group who developed dermatomyositis discontinued the medication, placebo. So the authors conclude that volixibat is an effective therapy to receive pruritus or to relieve pruritus in patients with PBC Change from baseline in adult itch pro scale was similar between the volixibat 20 milligram and 80 milligram cohorts. Reduction in serum bile acid levels were numerically higher, although not statistically significant, compared to placebo receiving patients. There were no new safety signals with volixibat compared with placebo. Given that the results were similar between the two doses of the medication, 20 milligram BID dose was selected for part 2 of Vantage continuing enrollment study, constituting a new promising therapy to address important symptoms in PBC of pruritus. So at this point of time, I would like to thank you all for joining us for day 2. And please refer to the landing page for slides and to claim your continuing education credit. Thank you all.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.